So uh, I suppose the baseline is that neuromuscular scoliosis, again, is a form of scoliosis that's often found in patients with neurological disorders, which may affect the muscles, or nerves. And the disorders can be progressive or non-progressive, depending. But typical examples are things like cerebral palsy, spina bifida, children who have been subjected to trauma at a very early age can go on to develop scoliosis. Even tumors in the spine can cause a form of neuromuscular scoliosis as well. So it's a multifaceted condition where so many neurological disorders can bring about its progression. So similar to the idiopathic scoliosis group, the first thing is noticing a curvature, which is often picked up by the carers, because a lot of these children have complex needs and learning difficulties. So, and the carers will pick it up either on direct visual assessment or symptoms such as failure to maintain an upright posture in a wheelchair. So a lot of these children are wheelchair bound. Or mobile for very limited periods of the day. But the essential thing is they spend lots of time in their wheelchairs, and it may become noticeable that they're no longer able to maintain an upright posture in the wheelchair, which then has consequences for their social interaction and overall general well-being. Then there are things like pain, back pain, and that often arises in the very severe cases where the top of the pelvis can be touching the rib cage, and that can cause pain. It can cause excoriation of the skin. If it's severe enough, they could even develop pressure areas, because there is a tendency to lean over to one side and predominantly be on that side for large periods of the day. So that can give rise to pressure areas over the buttocks. These children can, as the deformity gets worse, they can develop recurrent chest infections. It can affect the position of the pelvis as well, because a lot of them may develop changes in the posture of the pelvis, so that rather than being horizontal, the pelvis starts to tilt and rotate at the same time. And if it does that, that can give rise to secondary hip problems. So they can also develop pain from the hip problems. It could lead to discrepancies in the length of the limbs, which then makes it harder for them to sit comfortably in their wheelchairs. And generally, even behavioral changes. They may become more irritable. A lot of these children are not able to communicate the way that you and I would. And therefore, it may be that they're a bit more irritable, or they cry a lot more, or they wince every time they're moved out of the wheelchair. And generally, a reduced quality in life for the patient and their carers, because it also affects their carers as well. So treatment options, I always advise that that the simpler options are tried first. So simple things like, physio, we're talking about physiotherapy. So physiotherapy to try and prevent contractures and keep the spine flexible. And then things like modifying their wheelchairs, improving the trunk support in the wheelchair for these children, and even bracing. Although a brace is unlikely to work long term, but it can be useful as an interim measure whilst they wait for surgery. And then if all those simple measures fail, then obviously surgery needs to be discussed. Surgery in these children is very complex, places great demands on the patients as well. And so a lot of consideration needs to be put into making sure that the surgery is a successful undertaking. Yeah, well, I think it depends on how well controlled it is. So if it's well controlled, then a lot of these children will lead normal lives within the context of their neurological disability. If it's poorly controlled, like I said, it can affect their overall quality of life. I find that the main thing is not being able to maintain an upright posture in their wheelchair, because then that makes it difficult for them to maintain eye-to-eye contact with their carers, which is very important for social interaction. And then, even though a lot of these children will have complex needs and learning disabilities, they do have an appreciation for life. And just being able to observe their environment, feel part of it, is an important aspect to their overall well-being. So if you have a situation where, they're not able to maintain eye contact, they're in pain a lot of the time, or they're getting recurrent chest infections, meaning they're in and out of hospital, that can be quite distressing. And then some of them, may even require assisted ventilation, if they're getting recurrent chest infections, which are impacting on their ability to breathe, and means that they need that again, restricts their ability to lead normal lives within the context of their disabilities. Again, it's well, yes and no, in that if you're able to maintain the flexibility of their spine, then that means it's easier for treatment modalities like wheelchair adjustment or bracing are able to work better. But on the whole, the trend with neuromuscular patients is that those that are wheelchair bound are more likely to have a progressive scoliosis that will eventually end up with surgery. Whereas those that are ambulant are less likely. So if you have an ambulant child with neuromuscular scoliosis, the aim should be to keep them as mobile as possible for as long as possible. And that's where things like physiotherapy come into play. So in that regard, yes. But if you have a child with a significant curve who is already wheelchair bound, then the chances are that physiotherapy or similar treatments are not really going to arrest the situation.